I just turned it on.
Okay.
So I'll say it again. That
Oh, you just turned it on.
we are going to have a go-to meeting on Tuesday, July 7th. There was a mistake in the syllabus in not listing it. After that, we will have 2 weeks off for summer session. Okay, now let's see. I wanted to get back. Go ahead.
I was just going to say, after we have a webinar July the 7th, and then the next one is August the 2nd or August the 9th? August the 2nd. I guess we can say in July.
It'll be July 7th, and then July 27th.
Okay.
And that's it. Because after that, they're just papers are due. In the week of August 3rd, the paper on conceptual questions and issues is due. And then the synthesis paper is due on August 16th. And actually on July 27th, not only do we have a webinar, but the second paper on diagnosis is due. So everything's sort of squashed up at the end of the semester. Okay, I wanted to go back to our topic of last time and give those people who had not presented on their papers a chance to present. And that is, I have Tam. I have you down as not having presented your paper. Did I get that right?
Yes, you're right. But I'm unprepared. I needed to present at the webinar now.
Well, that's what we're going to do. Yes.
I'm sorry. I'm unprepared.
Okay.
I've had a blustery week. Let me have a look. I can see. Did you want me to just talk about the paper?
Yes.
Okay. Well, on the fly here, I wrote on cultural contexts. I thought it was might have had a little bit of experience of adjusting to new cultural contexts. Just trying to have a quick look. A lot of the literature writes about context and how important it is to keep that in mind in a clinical setting. That was a lot, I wrote a lot about that and how important that is. Obviously, it's relevant and probably a really highly and most prevalent aspect from which all other characteristics, the context, that is their context. So everything develops from that. We are products of our environment, essentially, and there's no greater context than a cultural context. However, having said that, I really found it interesting the more I looked at socioeconomic status, as we know, is a huge impacting factor to one's upbringing and cultural awareness. Even in diverse cultures, within a culture, the experience culturally is very different depending on the class you're born into and the social context within that. what I found really interesting was how that operates. Specifically, when you're talking about income, education, and occupation, and how whichever measure of those you take, essentially it's all the same. The lower that one is on the socioeconomic status hierarchy, the higher the risk for poorer mental and physical outcomes.
Mm-hmm.
So how does that actually work, and how that feeds into culture? You know, the social anomaly, this sense of injustice that occurs. And to break this down, I was looking at the research on what it is that motivates someone to get education and to be in education. Why do some parents focus greater on education than others? Because that's going to be the foremost characteristic that provides opportunities for a greater financial status or socioeconomic status. And how, what it is that actually motivates someone for acquiring that or achieving those things as opposed to not. So in a low socioeconomic environment, you have a sense of unjust and inequality, and the egalitarian status doesn't apply to you. You have an innate sense of outgroup as a result of seeing opportunities that are never within your realm or your society or your neighbourhood, your socioeconomic status, so, and your culture that is a part of. So with that environment, there's a learned helplessness that is cultivated, and it's that learned helplessness that is correlated with actually it's correlated with sense of delayed gratification. If one is able to delay gratification, it's usually because there is a sense that if you work hard and you do certain things, then you'll be rewarded. So you can delay the gratification. Without that experience and without that reality, without that as your perceived environment, then you don't have the same structured and realized sense of opportunity, so you'll get what you can, type of, in basic layman's terms. So that was, I thought, really interesting, how that actually is how that stuff is actually cultivated. So therefore, cultivating education opportunities and the importance of that, some people are able to grasp onto that idea or not. And I think that actually is a very interesting aspect in terms of being able to provide something really useful in a clinical context, is just giving information about that and making it accessible. And I mean, that's not a new thing. Everyone pretty much understands the importance of propagating good education. But it's actually the concepts of the availability of that, which is has been really interesting for me. So those things I thought were really, they trumped any kind of, even though the cultural context of that, you know, if someone comes into a new city or a new country and they are not within that culture, there's very often subcultures within the culture and they can fit into those. But if they are within a certain socioeconomic and a perceived consciousness, then the parents aren't going to necessarily, if they are of that consciousness, say if you look at thinking about children, if the parents have the consciousness that of this short-lived or the limited sense of opportunity, then they're less likely to place value and importance on that education, except if they've been informed otherwise or if they are educated otherwise and supported in that way. So I thought that was a really prominent aspect of the cultural influence, was the cultural influences and the context are largely to do with that sense of hopelessness or not, you know, hope. But more than hope, it's a it's a built-in cultural awareness.
Could I ask you a question, Tam?
Yes, please.
I found something that you said really interesting, the sense of the delayed gratification that you talked about, and having that experience and having that sense of there's something in the future that I know will be better, so I'm willing to hold out or do something now to get that reward. And some other experiences, they may not have that. They may not have that experience of delaying. So I don't know, have you come across any research or any readings that kind of associated that lack or absence of experience of delayed gratification with impulse control issues?
Oh, that's a good point. Not specifically with that designated disorder, no.
It's a very good point.
But,
I was just curious because I'm just thinking that maybe there might be a connection. I don't know if there is, but
yeah, I think it's probably. Well, I mean, those things are bedrock, really, when you're talking about cultural contexts and those fundamental belief systems of worth, really, it's self-worth. I don't think that anything characteristically is built on top of that. I mean, that's what I do think. So I don't think that anything that happens above that is not going to be affected by that foundation. So to what degree? But, I mean, there are so many different variables, and so many different, I don't know, personally I think the slightest instance in someone's life can really redirect anyone, and an example of someone that might be really incidental. It could be an aunt, or it could be someone on the subway. It could be something that a child sees that is able to create a paradigm for which they can build on various experiences. On the other hand, you could have another kid that has had the opposite experience, and so it's going to feed negatively. And I think that's where the cultural stuff will either extrapolate on the good or the bad, and depending on the opportunities, that's where it, and also then the family environment and diet. And
this is really interesting because when I was thinking about cultural context, I guess I was thinking about like culture as in different countries or different the way that maybe different societies may conceptualize issues of psychopathology, where one country may consider a set of behaviors to be pathological for their context, where another society may not even consider that to be pathological at all.
Well, I think there's certainly those aspects for sure, and I think with my paper I felt that I did talk about those things, but I felt that in any culture or country that you're in, within that there's a cultural context, and that is it. So I think that there are different different things to explore in cultural contexts, and I think that they can be, that I think I probably, it's a matter of choosing which one you want. There's a lot that you could look at within that too. But I think that with globalization specifically, I mean, when you're talking about a large portion of the world now being so interconnected, and globalization is a very real thing. There's access now to seeing different lifestyles, and so we are becoming, even though there are certainly cultural differences, I know for sure from personal experience, even within the same English-speaking context, the language is apparently the same, but there's a lot of different nuances that are different. However, I mean, I can speak to the things that, I've had conversations with my sister about various things that I hear and see here, having been here for almost a year, and I think, initially I was fascinated and intrigued and shocked about certain things. I'm not even going to talk about the gun laws, but, various things, and I'm thinking, the more I witnessed and the more I observed, things are pretty much the same. They're just slightly different focus on different things. So, but at the end of the day, if you've got a certain amount of income and you're educated, it's almost like we have access to understanding different cultural diversity a lot more easily than we ever have, and I think that's going to continue. But, I mean, Stephen, you probably can talk to us. I know that the psychopathology, particularly even in recent history with the DSM, was diagnostically quite different in Europe as opposed to America, and that would have had a different thing. But I think things are becoming a little more homogenized.
I'm just reminded of a personal experience I had when I worked with, when I lived in Canada and I worked with our native Indian population, a local tribe, and how the way they conceptualized, I hate to use the word psychopathology, but the way they conceptualized behaviors or events that were not of the norm was so different than the way I was trained in school. And then the way they handled that was also very different than the way I was trained. I mean, I participated in sweat lodges and healing circles, and then the way they dealt with the individual who had an issue, it was just really, really interesting, and it's so different than the way I conceptualized it, or that I had learned, that when I'm reading about psychopathology and about like certain symptoms or behavioral definitions that go along with a particular syndrome, it just made me think, who is making this up, and to which culture does this belong to, and is this applicable to other cultures? So I just had the questions, no answers, but just some questions about all of that. Yeah.
I sort of feel like there's still that bifurcation. When you're talking about Indigenous cultures, it's almost, there is a disparity there that I don't know when and how that's going to be reconciled. I don't have, and I'm very conscious of it too. I mean, I've had a fair bit to do with Australian Aboriginal culture, and I've done sweat lodges and been engaged in Buddhist events and a number of different things. Was a Qigong instructor, so I learned about Chinese medicine. I've done a lot of different, and my main interest is complementary treatments. So I have a real problem with the whole, not problem, but I'm very mindful of labels and those sorts of things. But I think that it's important for me to sort of bridge it somehow. Find a way to, instead of saying, oh, this one's, I don't know what the answers are either. It's really difficult. I still find that there's a language for this, and a consciousness or awareness for that, and they can meet, they can cross, but it's still, it's new. But I was really, I guess, I don't know if I spoke about this last time, but I was encouraged by discussions, by presentation. I think I spoke about this last week, the week before, by presentation from a very well-respected researcher at UCLA who presented on complementary treatments and specifically yoga and yoga therapies. And he was it was so inspiring and relieving to hear his communication in a scientific format. So he was one of the first people I knew who really did that well. He was able to actually bridge this consciousness and spirituality, if you like, into a psychiatric medium. And I was really impressed. So, and like I said, and encouraged that that's occurring. So I just want to be around more people to get better at, because I feel like I'm still not sure, and I don't have the ownership of what I'm doing here. Barely 1 year in yet, just getting my head around these concepts. I think I have to know those concepts first before I can try and translate or amalgamate.
Yeah.
I don't know.
With respect to PTSD, Bessel van der Kolk, who's one of the most prolific psychiatric writers, has come out recently with a paper that just says that you can't do psychological work with people who are suffering PTSD, that it has to be a combination of body work and psychological work. And that's an amazing statement. And it's also important because it comes out of a scientific, quote unquote, a research in scientific context.
Right. I think it, I mean, for me, that's always made sense. But like I said, I'm really a long way off having any kind of mastery over this domain before I'm able to actually speak with conviction about why it is or isn't those titles and those labels exactly. You know, I think it's fascinating, and it's why I'm here, really, to get better at doing that and to contribute in that way, because I think it's the most valuable thing we have going, and it's the only way that we can move forward. You know, as a species, really, right? That sounded a bit grandiose, but yeah, it's true. Things are shaking down.
Things are shutting down? I didn't hear what you said.
Yeah. Well, you know, like when you're talking about global issues with global warming and the use of our resources and the ubiquitous political circle and cycle that we're going, and the diseases that we're not curing or that we're perpetuating through pharmaceutical sponsorship, I don't know. I'm very hesitant to get too political about it.
I think that is one of the things that makes it so hard, that within one's own culture, it has become politicized. So it's actually, I think, easier to go into other cultures and be understanding of the various points of view than it is to be in one's own culture. Just because you were raised in the center of it, with privilege or without privilege.
Mm.
Okay, thank you very much.
Thank you.
Anne-Marie. Anne-Marie just sent us a note saying that The Body Keeps Score is a book of Bessel van der Kolk's, and it's wonderful. So you can check on your lower right-hand column and pick it up as a book. Anne-Marie,
Sorry,
talk about your paper. I think that you're still on mute.
Hello, can you hear me?
Yes.
All right, I am sorry about that. I decided to write on the topic of etiology.
Mm-hmm.
And I think what I found most interesting at first was that some of the articles that I read, it was kind of like an intro to genetics class. And I found some of the information, it took me a while to decipher just some of the basic vocabulary. I don't know if anybody else had a problem with that, if they read any of those articles, but it was very interesting. I kind of got a little focused and a little intrigued in the area of how the differences between etiology and pathogenesis, and I don't know if I'm pronouncing that word correctly. And I wasn't really, I guess I didn't realize when I was writing this paper that what the differences between those two terms were until I kind of looked at it from a medical basis. And for those of you who may not know the difference, pathogenesis is kind of how it happens, and etiology is kind of the root cause of it. I hope I have that correct, because that was my understanding of it. As I read through the material, I was interested in kind of learning more about epidemiology. I didn't know that much about it, so I found that the discussion about breaking down an individual's kind of vulnerability and their susceptibility and risk factors, how they contribute, and the precipitating conditions. the course and development of psychopathology arises. I thought that some of the reading was interesting, and I kind of talked about how the fields of neuroscience and psychoanalysis and psychobiology have kind of all come to meet together, and how we're, even though we've learned quite a bit, we still have such a long way to go as far as how we look at things. Nature versus nurture was what I learned, I think, in Psych 101 many, many moons ago. And although I think we've come a long way, I feel like we still have so far to go as our technology advances and we learn more about genetics, and we can get further into the rabbit hole of DNA and understanding what are the causes, environment versus genetic factors as far as the development of psychopathology. I think that one of the biggest things that I took away from the readings and that I talked about was how all of this led to emotional development and psychopathology in general, and I kind of related it to how I work with clients. I do neurofeedback, and I get a lot of questions from parents that I don't have the answers. We do brain mapping at our office, and we can see on a biological basis, we can give them answers as far as this is why you see what you see with your child, but they almost want us to go a step further and want to talk about, well, did this happen during their prenatal exposure to drugs and alcohol, or did this occur during some of the neglect or the abusive environment that they were in during their early childhood, or did this happen in our home somehow? And I think that there's probably technology out there that can maybe help with that. Unfortunately, we don't utilize it at the office, but I kind of, in my reading and all of this, I found it very helpful in understanding on a deeper level as far as heritability, genetics, and the course of the environmental experiences of how things are the way they are for individuals, and how it's not a one-size-fits-all, and there's so many factors that can interplay and go into the making of pathology for an individual. So that's kind of what I took away from this and what I wrote about.
Thank you. Let's see. Thomas, I believe that you have not presented your paper. Is that true?
That's correct. Can everyone hear me?
Yes.
And am I echoing?
No. Not at the moment.
Okay. Shoot, I was hoping I would be echoing so I could just claim technical difficulties and not have to report on my paper. But all right, so two tough acts to follow there, but I'll just give some thoughts on what I wrote about. I also chose to write about etiology and pathogenesis. And I guess my paper sort of just focused on, I can't remember the name of the author offhand, but in the Oxford reading, it was chapter 3. The author just brought up a lot of really important points about how it's basically methodologically impossible to really pinpoint exactly where manifestation of a mental illness today came from. We can have excellent sort of post hoc guesses. We can have terrific, correlational theories, but there's just too many. There's just infinite numbers of confounding variables as to how the person sitting in front of you today came to be suffering in the way that they are. So my paper I kind of approached it from, well, then maybe let's just accept that for what it is, and rather than try to have sort of, I guess, territorial fights between the various schools of therapy, the cognitive approach says it's about let's take a depressed patient, for example. The cognitive therapist might want to look at, cognitive distortions, or, the negative self-talk. Or the psychodynamic person might want to look at, well, this came about because of early childhood stuff. Meanwhile, you have a patient sitting in front of you who feels like they're under a rain cloud and they're considering how they can end their life. So it kind of just comes down to, in the patient's perspective, does it really matter so much where it came from as what the hell can you do for me now to end this suffering? And that's not to say that it isn't important to know how it came to be, because you can't form an intervention without having some idea of what went quote-unquote wrong and how you can rectify that through therapy. And also, from an epidemiological standpoint, early intervention or learning how to sort of preemptively offer somebody support before something becomes overwhelming to them. So not to say that looking backwards in a person's life and trying to pinpoint where it came from is unimportant, just maybe recognize that since we can't exactly know, maybe we don't need to exactly know, and we can start looking more and maybe just appreciating correlations with, adverse life events, and just honor the fact that correlations can get us pretty darn close. In my paper, I kind of gave a free pass to sort of the biomedical school of thought, because I think that is the one field that theoretically could potentially someday identify a specific marker or a specific, something in the genome or something in the blood or some kind of test that could be used to, figure out exactly what happened. But short of that, I think the field of psychology might be just better serving those whom they wish to help by looking at, integrating all of the various possibilities of how a mental illness came to be in a person's life, rather than just, again, sticking with your one school of thought. And in my paper, I just talked a lot about the importance of correlations, even if they aren't scientifically exact, but they can still be helpful in identifying people who are at high risk. So I guess I shifted from etiology to intervention, which may have not been the best approach to the paper. But I guess that's sort of the dichotomy I went with. Was it's probably not the most important thing in the world to know exactly how a mental illness came to be, though it is important. It's not to be ignored, but I think, from the perspective of the person suffering, I think that effective treatment is probably where research should focus. And so, that was kind of the gist of what I wrote about.
Thank you. To get back to the issue of culture, I think more than anywhere else in the United States, the entire focus is on the immediacy of getting rid of something. Mm-hmm. And that is extremely important, and therefore we tend to look for a answer for everything through medication.
Right.
And that rather than taking an integrated approach, which is the only approach I believe you really can take in successfully working with a wide variety of people, then instead of doing that, people are caught in their own sort of religion.
Right, their own orthodoxy
their own orthodoxy. Yes, they're caught in their own orthodoxy and are not able to actually do their job and engage the task because the orthodoxy is telling them what to do, as opposed to the patient telling them what to do.
If I may, if I could add to that, I think in children and adolescents in particular, I think that parents get pressured by schools quite a bit for behavioral management. And you have many kids and adolescents that end up being put on quite an array of medication in order to try and manage the symptoms rather than take a look at what is going on in order for the schools to be able to manage them. Or I don't know if anybody else has that experience, but we have kids that come in on 7 and 8 different psychiatric medications, and they're all kind of working against each other, and it can be quite an issue at times.
what we want to question is who was it that decided that 5, 6, and 7-year-old boys should be sitting in a classroom for 6 hours a day?
Exactly what I was thinking.
And that
The whole education system.
that damn, Charlotte, your your muting is on.
I volunteered in my daughter's first grade classroom last year for 2 hours a week, and fully 3/4 of them would kneel on big stuffed animals because they couldn't sit in their desks and be still. And they'd be trying to do a math worksheet or something, and they'd be just bouncing and going like this the whole time. Fully 3/4 of them. So clearly that's normal behavior when you're 6 to try to have to learn how to sit still in a seat, to a certain degree.
Right.
Not that other people don't have more problems.
Right. And I think that's an important example because if we're doing that with children, we're doing that with ourselves as well. We are, everything is prescribed.
Yeah. In my experience too, though, it's definitely the schools give pressure for that kind of thing. But also, and I'm not at all my perspective is not to blame the family or look for the deficit in the family, but there are a lot of parents too who would maybe rather put their kid on several medications than take a good hard look at the ways in which their family and their lifestyle maybe isn't working for their particular child. So I think that's a factor too. People, it's hard in today's culture for a lot of families just to get by and to even think about changing that radically because it would suit their child better, or to maybe take a really good look at their relationships and the time they're spending with their child and what that looks like is just too much for them.
I see.
Yeah.
I was going to mention that David had written a comment saying that we're a very knee-jerk reactive society, and I wonder if, just as a society, the reason that we're going towards 3 ways to heal your marriage or the pills is because we're having difficulty with delayed gratification and taking maybe the longer route to help.
Why would I want to wait?
Sure. Yeah, I'm really intrigued about looking further into the ramifications and just how much delayed gratification has to do with it. I mean, I've been practicing meditation for about 13 years, so I'm an absolute advocate of transcendental meditation specifically because I know what it's done for my life and I've seen what it's done for others, and I'm passionate about bringing this to anyone I can in order to facilitate greater groundedness and more coherent nervous systems. Basically, it's just the nervous system, and it's just being still and being centered and within for at least once a day. If you can do that, it changes your life. I mean, and people are aware of this, and there's been a lot of study on it, a lot of research, but it's really not as prioritized in I guess in the pharmaceutical world of medicine, and although it's changing slowly, and it has to, because I think it's really, like you're saying, the knee-jerk reactions and the quick fixes are really just delaying the inevitable, which is worse scenarios. I mean, it just builds on one thing after another, and until you stop and disengage from that, and then you can do more, and you're more relaxed, and relationships improve, you're more solid and peaceful person to interact with. So that frequency affects everything around you.
And speaking of culture, I mean, and meditation, I think that there's different creative ways that families and couples can learn to put some of those ideas into practice without necessarily feeling like, oh, I have to do this Buddhist meditation because that's not our thing. You know, just getting families to maybe look at the patterns in their family, how it's affecting maybe a more sensitive child or a younger child, in terms of, well, how often are we very still? How often do we slow down? Do we have time where people are really listening to each other? Everybody's not going out the door at 4 different times on 4 different gadgets on the way to get to 4 different sports practices. You know, not that any of those things are bad, but that families can look at how do I put some of those basic principles into practice in a way that fits my relationships, my family, my culture.
I'm thinking that it would be really tricky because just as a society, we're heading the other direction. We'll do HMOs where you get a certain number of sessions to fix anything. It's easier to pop a pill than spend 20 minutes sitting still or spend 20 minutes playing with your child. So I just feel like when we're talking about this, how do we impact our culture?
So I've thought about this a lot. And I hear what you're saying, Charlotte. And I've said it myself. You know, well, even though I know personally the difference between an actual focus, like a mantra focus or a point focus meditation, but when you're talking about mindfulness and, you know, being more aware of the 20 minutes on the kids, and that's an aspect that's worthwhile. But to facilitate that actually requires some kind of physiological shift, because you've got that. It's beyond this. Like, it's not a decision. Oh, I'm going to act. You're coming from a different place. And I honestly think, for me at least, I'm at the stage now where my research and my dissertation, all this stuff is going to be focused on specific types of meditation that are going to facilitate. That's where it comes from. You don't get to a place and then go back in. It comes from the other way. You have to be still before you can change the rest of it outside, like all the behaviour and all that stuff. It doesn't. I don't know that it. And I think that a lot of people, when we're talking about making effective changes, I know that in my journey with this, I'm only just now stepping into more of a polarized position with them. I actually know you need to do that to be able to get that, rather than, oh, look, it's nice just being, and absolutely being in nature is probably one of the greatest, you know, positive things that we can do for ourselves in terms of changing our state and making a difference and being in tune. But I think that there's nothing quite like a daily commitment to something and then waiting for that to change. And, you know, I think that for me personally, I guess that's my soapbox for now. You know, I think that is really the one thing that we're going to be able to do in terms of prescribing. Okay, you have just try this technique, do this, and then, you know, and manage the other stuff. Maybe then slowly wean off the meds later if you can. That stuff will fall away. And the diet, it happens from that way. It doesn't. I don't know if I'm making sense, but
you are. I guess I'm always coming from more different perspectives, right? Like, I'm always coming from this attitude of you know, thinking about a busy family with young children or something, and certainly you're not going to get a young child to set up
absolutely.
a really practice.
I think that's why it's important to be able to get things like meditation in schools, so that the kids are going to be dropped off at 9 o'clock. Everyone, and then it's just a part of the program, you know, and the teachers are too. And that way, you know, at least they're not relying on the parents' ability to shift their.
There is some effort. It depends on where you live. Like in my daughter's Northern California public school, they have a program that I think is pretty good, but it really depends on how good the public school teacher is at implementing it too, right, and how much they believe in it. That's about a little bit better emotional management during discussions. And me and some of my friends joke around that it's mini marital therapy with second graders, and it's just ridiculous. They're like, no, I mean, I see how you feel. Just give it to me. You know, they don't care. They're like, whatever. But I mean, to a certain extent, it does help them slow down a little bit before they clobber the other guy and take it. But I mean, but it's funny sometimes seeing like 2 6-year-olds get coached on. I hear what you're saying, and sometimes it tickles my cynical funny bone. But I think there are efforts like that in the schools. But I always think of like John Kabat-Zinn, and he talks about, you know, his family, and, you know, wherever you go, there you are. And you can start with, while you're washing the dishes, wash the dishes. While you're brushing your teeth, brush your teeth. And I think for a lot of families, just that would be a godsend. There was this book I read. It was just a photojournalist wrote it. It came out like 4 years ago. It was called Buzz, and it was one woman's journey with her family and ADHD, and realizing that she also had it, and then all the different things she tried with neurofeedback and taking her kids around to these CHAD meetings, learning about the pharmaceutical industry. And in the end, she really realized like how much she needed to look at her relationships with her child and some of the negative patterns that they had built up between the two of them, and that it wasn't just his needing his meds or her needing his meds, or that it was all this constellation of factors. And she was an unusual person in the effort that she was willing to put forth, for sure. You know, they ended up doing some meditation type things together, her and her son, all the way from when he was like 8 to 19. It was a good book. I recommend it if anybody likes to read that kind of stuff. It was just a novel. I mean, like, it was true, like, I guess an autobiography kind of, but she changed some details. Yeah.
Okay, it's we only have 6 minutes, so I want to go into what we'll be doing in the webinar on the 27th. By that time, I'm sorry, on the 20th, on July 7th. By then, we will have read about schizophrenia, about anxiety disorders, about major depression, bipolar disorders, and 1 week of personality disorders. What I would like you to do is to find something within the context of your reading that speaks to you with respect to wanting to present. Like, review a chapter, one of the chapters or one of the papers, and choose a topic on one of these 3 syndromes and be prepared to present it on July 7th.
Could you outline, so we're talking about personality disorder, schizophrenia, and another disorder, or those 3 topics?
And major depression and bipolar.
Sorry, say that again? Cut out.
Adding to the ones that you said, both personality disorders, schizophrenia, anxiety disorders, major depression, and bipolar disorder.
Thank you.
Is our presentation just going to be like it usually is, just we're discussing, we don't have to show any?
No, you don't have to show any slides. I mean, you can if you want, but you don't have to. It's just a discussion. I mean, everybody will have read the material, so you don't have to start from scratch. You can just assume a bit of knowledge and just that you chose it and get further with it. Okay, is there any questions? After the week that includes July 7th, we will have the week of July 13 and July 20 off, and we'll come back to substance abuse. And what else? substance abuse. Okay, and
Yeah.
for the webinar, we will, on July 27th, we will discuss personality disorders again, because I think that they're important enough to have two discussions on, and a beginning one on substance abuse disorders. Okay, does anybody have, go ahead.
When is the next paper due?
The next paper is due on the end of the week of July 27th. So that's August 2nd.
Professor Ruffins, should we select a chapter and just prepare beforehand, or would you want us all as a group just to have a really clear understanding of every single chapter and we just kind of present on a whim that day on July 7th?
No, I think everybody should read the chapter and be relatively familiar, but for the person who's presenting, I would just want them to focus in on one paper or one chapter.
Okay, and should we pre-select that, or
Yes.
somehow?
I mean, you should pre-select it. I don't want to select it for you.
Yeah, I mean, as far as like having like a discussion forum where, you know, I could type in and say, hey, I want to do PTSD, and somebody else can say, hey, I want to do bipolar. Something like that? Is that what you had in mind?
No, I think that there's it's not only talking about PTSD, but within PTSD, the paper probably should not be a paper on depression, but some aspects of depression that you find telling.
Yeah. Yeah, sorry, I misunderstood then. I thought we were talking about the next go-to meeting webinar when we all are asked to present on some reading.
Yeah.
I was talking about that, not the paper, but just the next presentation.
No, we are talking about that. We are talking about the webinar.
Okay.
So given
they are.
Go ahead.
Yeah, they're two things. There's a webinar on July 7th where we present the readings of a chapter, say the 3 chapters in the anxiety disorder reading.
Right.
And then there's also a paper at the end of July / early August for a paper on a specific topic related to a diagnosis, right?
Right, right. To pick one of the diagnoses that we've read about and write a paper on it.
Right, okay.
Remind me on July 7th to talk about the structure of the second paper that's due on August 2nd. I've had a chance to do one go through with your papers. And I just want to give you some hints about how to approach the second one. Okay, it's exactly 9 o'clock. I think we should say goodnight. And I'll see you in 2 weeks. Good night, everybody.
Thanks.
Bye.
Bye, everybody.